Good afternoon and welcome to today's IAC webinar, Pedal Acceleration Time, PAT, Technique, Criteria, Interpretation, and Clinical Application. My name is Marge Hutchison. I am the Director of Accreditation for Vascular Testing at the IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar as we monitor those questions throughout the presentation, and we'll try to answer as many as possible during the Q&A period. Also on the left sidebar is the Resources tab. Click this tab for links to today's handouts, which include PDF copy of today's PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left corner of the player, please note the Request Support button. If you experience any technical problems during the webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right side of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the SVU CME credit, you must be registered, logged into this webinar, then complete the survey at the end. The link to the survey will appear on the screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged in to this webinar on another computer or device so that we have a record of your attendance. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. And now I'd like to introduce our guest presenter, Jill Sommerset. Jill Sommerset is a vascular technologist with more than 25 years of experience in advanced vascular ultrasound and limb preservation. Currently, she is the Director of Ultrasound at Advanced Vascular Centers and Hope Vascular and Podiatry. She is also the Director of Clinical Education and Training at Avera Medical. She is known for developing pedal acceleration time, a technique to help lower limb perfusion assessment in complex CLTI patients. Jill is also an international speaker recognized for her contributions to vascular ultrasound and improving patient outcomes. She is dedicated to advancing patient care through innovative techniques. With that said, I will now turn the webinar over to Jill Sommerset.
Wonderful. Well, thank you so much, Marge, for that kind introduction. And really thank you to the IAC for the opportunity to share more about pedal acceleration time on this webinar. Here are my disclosures. So I think we can all agree that our patients are really complex. There is a rise of patients with diabetes, renal failure, and therefore the calcium burden in the tibial arteries and below the ankle into the pedal arch is quite calcified and really can be difficult to evaluate with our non-invasive tools. And I think ABIs and toe pressure served us well for decades in our smoking population. And yes, we do look to toe pressure in these diabetic patients, but I'm here to talk to you about pedal duplex, another way to evaluate perfusion in the foot in these complex patients. Because we all have patients like this where it's really challenging. The ABI is not compressible, and now you have this non-healing wound, and we have to tell our vascular surgeon or vascular specialist, what does the flow look like to the wound bed? And that can be really challenging. And again, these are patients that we see in our daily practice that really require, I think, an advanced tool, a scanning into the foot using pedal duplex ultrasound. Now, I'd like to give you a historical vignette of PAT because it's been quite a journey. In May, uh, 2017, actually got really frustrated that I couldn't tell my vascular surgery colleagues what the blood flow was like in the foot in complex CLTI patients. And I really, uh, out of curiosity, scanned my own foot and realized I could see these arteries really well. And I journaled on the back of a parking ticket what I was thinking. And I talked to my vascular surgery colleague, Dr. Tesso, said, I think, we can do more with this. And he was like, awesome, let's do it. So we would whiteboard in a small community hospital in the hall room, in the hallway, and really put our mind to understanding pedal perfusion. And this was really a landmark photograph in July 21st, 2017, when he said, like, let's come into the cath lab, let me open the vessels and see if we can see the change using pedal acceleration time. And we did. And that was really an extraordinary moment. I think we know this guy, Dr. Beach, well known to the vascular community. I called him and I said, I think we need to get on a webinar or a Zoom call. I need to talk to you about these ideas. And of course, Kirk is so open and honest and so smart, and really validated what we were thinking and the use of acceleration time in the pedal arteries. 2019 was really an integral time point. So from 2017 to 2019, this group was just instrumental in this collaborative approach to really understanding foot perfusion and research. We published our first paper in JVU, talking about the technique. And then in 2019, we published the criteria of PAT in the Annals of Vascular Surgery. So moving on, I'm here to just talk to you about PAT, but we have all of these other non-invasive tools available to us in our toolbox, and they are appropriate to the patient in front of us. So I'm not saying that PAT is the end all be all. I think we have to use the tools available to us in the patient that is in front of us and how they present. So in patients with CLTI, missing toes, forefoot amputation, pedal duplex is a really helpful tool in assessing perfusion. And it's really nice because pedal duplex really unlocks so much information. We can not only look at perfusion, we can understand the anatomy, we can evaluate the calcium burden, and we have the ultrasound tools to understand hemodynamics, antegrade, retrograde, direct, indirect flow to the wound bed. And that really tells us a lot of information of the status of the patient. So this is the 2019 criteria where we looked at 499 limbs, and these were all non-diabetic, non-renal failure patients. And we compared PAT to reliable ABIs and clinical symptoms. So PAT, or pedal acceleration time, is a measurement in time. We measure this in milliseconds from the onset of the systolic waveform. This is the arterial waveform in the pedal arch. We measure from the onset to the peak, and we take that time in milliseconds and apply it to our published criteria. So PAT has 4 classes, class 1 being normal, class 2 being slightly abnormal, more in line with a claudication, and class 3 is more in line with maybe ischemic rest pain, non-healing wound, and certainly class 4 is the worst, where we have non-healing wounds, and this is consistent with CLTI. Now, this is a spectrum, but this criteria really gives us insight to the status of the pedal perfusion. And PAT really is becoming a common language. Like, what is the PAT? Class 1, class 2, class 4. And so this is really evolving globally. So fast forward to 2026, and again, this journey has been so collaborative around the world with many vascular specialists and physicians doing research. So we now know today in 2026 that PAT correlates with clinical symptoms, reliable ABIs, toe pressures, and TCPO2, and it is a predictor of limb salvage. And there's many papers. I put some in the resources for this webinar, but this is a really nice paper out of Portugal where they looked at PAT compared to TCPO2. This is the 2 papers that Dr. Tesso and myself and colleagues published, and this is how we know that we know that PAT of less than 180 milliseconds is enough to heal a wound, and that's outside of any major infection. So this paper is in 2021, and we looked at patients pre and post-op intervention, and 80% were endovascular revascularization, 20% were open bypass. And again, we know that a PAT of less than 180 will heal a wound. In 2025, this was a really great paper because we looked at 54 patients, all diabetic, with isolated infrageniculate disease. And we found the same thing. A PAT of less than 180 milliseconds after limb salvage was enough to heal a wound. And what's more interesting, it was regardless of where the flow was direct or indirect to the wound bed. This is a nice paper out of New Zealand where they looked at PAT as a surrogate in patients with a 4-foot amputation. And more recently in 2025, this is a multi-center study looking at the diagnostic accuracy of PAT. So these are all papers, and there's more that I think are worth the read if you are interested. So to date, there's been over 30 plus peer-reviewed papers, 17 clinical studies, and that involves over 14 countries. So let's talk about the clinical application of PAT. And really, this is a foot first approach in patients with wounds. And you can see here that these patients are really challenging. Their ABIs are non-compressible. We don't have digits to do a proper toe pressure. Maybe we can get a waveform on maybe that large toe, but all of these patients have class 1 PAT, meaning that these are neuropathic diabetic foot wounds. And it's really nice because when you start at the wound bed, you can quickly evaluate, is the flow adequate or not? This patient has this infected second toe, and we need to know, can we amputate the toe? And does podiatry have the confidence to say, can we amputate the toe and the patient will be okay? Well, after vascular testing, this patient has class 1 PAT. They can do a second toe amputation, and the patient did really well, saving this patient from an unnecessary angiogram. Now, these patients are clearly ischemic. These are all patients that, in my mind, when I see a patient like this with class 3 or class 4 PAT to the wound bed, I am certainly going to scan this patient with the intention to map for any sort of intervention, whether that be endovascular revascularization, open bypass, or deep venous arterialization. So when we start at the wound bed first, it really sets the tone to what we are anticipating to find, which is significant disease in these type of patients. So let's do the anatomy and technique review of pedal duplex ultrasound. Before we talk about PAT and the pedal arch, I really want to highlight the communicating arteries because I think they're underevaluated in the normal arterial duplex, and they can be incredibly helpful to really understand the hemodynamic pathway. I'm always thinking about the target artery pathway to the wound bed. So how are we going to get blood flow to that wound bed with an intervention? And these communicating arteries, we all have them. They lay dormant until we need them. Like, think of the circle of Willis. Um, you know, when we see hemodynamic changes, now we see some collateral pathways start to kick in. So the intercommunicating artery is a connection between the perineal artery and the distal anterior tibial artery. The posterior communicating artery is the connection between the perineal and posterior tibial artery. And these communicating arteries can be bidirectional. It just depends on the demand of flow. So angiographically, we can see here, this is a very atretic perineal artery, and you see these nice little serpiginous communicating arteries between the robust anterotibial and posterior tibial artery here. So this is angiographically what it looks like. But from a duplex perspective, gosh, these can be so beautiful to scan. So if we look here, you see the occluded anterior tibial artery, and we all know we have reconstitution of vessels, but where does it come from? And so I like to scan the perineal artery from this lateral approach, and you'll see very nicely the distal perineal and the communicating pathway to the reconstituted anterior tibial artery. So how I scan these is I take the probe about 2 finger breaths above the lateral malleolar bone, and you're going to image the anterior tibial artery. you can already see the CTO cap. Here's the occluded anterior tibial artery, and you start to see this nub of flow. And if you take your probe and you just fan the probe a little laterally and apply some pressure, increase your depth, you will then see the communicating artery, and the perineal artery lies deep. So understanding the flow pathway is important in patency. And if we put a Doppler in this reconstituted anterior tibial artery, it's not bad, right? Do we really need to open up this anterior tibial artery? And the likelihood is no, because this waveform is pretty good. Now, for the posterior communicating artery, it's the same technique, just on the medial side. So 2 finger breaths above the medial malleolar bone. And you're going to image the posterior tibial artery, and you'll see this nub of flow, which is the posterior communicating artery. And the perineal artery will just lay deep like we normally see it. So now we understand the communicating arteries, and now let's talk about PAT and the pedal arch anatomy. So from the anterior circulation, we have the dorsalis pedis artery here, and it's going to bifurcate into the first dorsal metatarsal artery and the arcuate artery, which is going to dive like a waterfall. But when we talk about getting PAT, the most important place to obtain a PAT is going to be at the wound bed. So once you do that, and I'll show a picture of that, we can look at the first dorsal metatarsal artery, arcuate artery, and then on the plantar circulation, we can evaluate the medial plantar, lateral plantar, and deep plantar. Now, we all probably evaluate the posterior tibial artery to about the ankle, but it's really important that we keep scanning below the malleolar bone. And technically, this is called the common plantar artery, and then it's going to bifurcate into that medial and lateral plantar artery. So a lot of disease sits here, so it's really important to just scan a little distally, not to miss any disease in that common plantar artery. So, in regards to a pedal duplex protocol, which is a billable code at 93926, this is a limited unilateral duplex ultrasound. We're going to evaluate the wound bed PAT first. And just like I said, the arcuate, first dorsal metatarsal artery, medial, lateral, and deep plantar, as well as the distal anterior tibial, posterior tibial, and perineal artery, and then evaluate the communicating arteries. And I'm going to talk about how we integrate PAT, this pedal duplex, into clinical practice and where it provides the most value. So just stay tuned for that. So let's move on. This is the wound bed. So PAT is very forgiving. So regardless of where the wound is on the foot, just place the probe proximal to the wound bed. And you can see here, this guy had a fifth toe amputation. This wound is not healing. So this is actually the lateral tarsal artery coming off the dorsalis pedis artery. But even if you don't know the name of the artery that you can insunnate, PAT is class 4. We've answered the question. There's not enough blood flow to this wound bed. You can just say class 4 PAT, or the wound bed PAT is X. Maybe you can just describe the anatomical location if there's multiple wounds. Here's another example of a small heel wound. This patient has been revascularized, so I'm going to place a probe at the medial calcaneal branch to this heel wound and obtain a PAT. So again, just go to the wound bed first, and then we can now go into the pedal duplex ultrasound. So let's talk about the arcuate artery. The dorsalis pedis artery, we all know where that vessel is. And if you place the probe in long axis, indicator towards the head, very light probe pressure because these are superficial arteries, your probe is going to be anchored to what's called the cuneiform bone. And if you feel it on your own foot, it's the top ridgy bone that you can feel. And if you slide your finger just distal to that is a soft tissue window. So from an imaging standpoint, you're going to see the cuneiform bone here, big shadow. Here's the distal dorsalis pedis artery. Here's the bifurcation of the arcuate and first dorsal metatarsal artery. You should see no bone on the right-hand side of the screen, which is towards the toes. And if you look at this color filling, this patient has a very low calcium burden. We see beautiful color filling. So we can take a PAT in this arcuate artery, and a lot of people ask about angle correction. Angle correct in the pedal arteries just as you would in any other bed of the body, okay? From here, you're going to just slide the probe just a little distally, and you can evaluate PAT in this first dorsal metatarsal artery. Now, if this patient had gangrene of the first toe, I'm going to slide as distal as I can, probably take a PAT out here just to ensure that the PAT is adequate. And you can see here that the PAT here is 83 milliseconds. And if you notice in all of these examples right here, the waveform is really large. And I'm going to talk about diagnostic accuracy of the measurement of PAT because we can't measure a tiny little waveform. We have to have a very large waveform. So this has concluded the dorsal evaluation of PAT, wound bed, arcuate artery, and first dorsal metatarsal artery. Now let's go to the bottom of the foot. And a lot of people have, they struggle with the lateral plantar artery. And so it's really important that we understand the external landmarks of how to scan. So you're going to place the probe in a transverse view at the midfoot, and you want your probe to be in line with the fourth toe. So the middle of the probe right in line with the fourth toe. And you're going to start to see some vasculature. And from here, you are going to take the probe and do some compressions and just compress the lateral plantar vein. And luckily, the pedal venous anatomy is pretty generous in these patients. So once you see the lateral plantar vein, just focus on that. And then you're going to elongate your probe. Again, probe in line with the fourth toe and indicator towards the heel. And the reason is it's going to feel weird to scan, but you want your toes to always be on the right-hand side of the screen. So once you've elongated the vein, now you can turn on color and you're going to see the artery right next to the vein. And we're going to lower the baseline down. We're going to decrease our scale and measure the acceleration time of this lateral plantar artery. We do not do prox, mid, and distal lateral plantar artery. We just need one at the mid lateral plantar artery. And then we're going to slide the probe more towards the ball of the foot between the second and third toe. Because remember that pedal arch connects to that arcuate artery on the top of the foot. And the deep plantar artery is just, it's like SFA to pop. It's just a continuation of the vessel that's going to then meet the arcuate artery. And this deep plantar artery is going to dive. And the next step is we're going to slide back to the lateral plantar artery landmark and just slide your probe medially. So your probe is in line with the first metatarsal head. And the major landmark here is the hallucis longus tendon. We're going to apply color, and that medial plantar artery lays superficial to that hallucis longus tendon. And generally, the medial plantar artery is smaller in caliber if the lateral plantar artery is patent. If the lateral plantar artery is occluded, the medial plantar artery is generally spared and will be more generous in size. So when we put all this together, we talked about the communicating arteries, the pedal arch, PAT, you start to really understand the pedal hemodynamics, which is really, valuable in the setting of CLTI. I do want to mention heel wounds. Dr. Tesso and myself and colleagues are working on heel wound research because we have found very good results in evaluating the medial and lateral calcaneal branch using PAT because it can be a very challenging wound bed to evaluate. So the medial calcaneal branch is a branch off the posterior tibial artery. The lateral calcaneal branch on the lateral side is off the perineal artery. So when a patient presents to you with a heel wound, you want to look like where is the wound located? Is it more medial sided, lateral? If it's a full thickness heel wound, you certainly want to evaluate both the calcaneal branches. And you can see my probe position here. The probe drops below the malleolar bone. You can see the calcaneal bone right here. That calcaneal branch just rides just next to that calcaneal bone. This patient here at class 4 PAT, after revascularization, went on to class 1 PAT and healed his wound very nicely. This patient had a medial sided heel wound. So now I'm thinking about the medial calcaneal branch. And so class 4, pre-procedure, class 1, he did very, very well. So a lot of promising results in evaluating heel wounds. Now, some may say like all those examples are really beautiful, but what about real life scenarios? These patients are really hard. So my advice is to just optimize the image just as we would in any other bed of the body. The tibials can be very challenging to scan because they're calcified. Look at this perineal, calcified vessel. We got a little color here, but the waveform isn't that bad. When we translate that to the foot, you are going to see these calcium lined pedal vessels. And yes, they are tiny. Sometimes they can be 1 millimeter. But this is a metatarsal artery to a foot wound. You can see the calcium. Put a Doppler in there, and we have a measurable class 1 PAT post revascularization, and this patient did very well. I do want to talk about like really looking at the calcium burden. So I talked about those compressions with the lateral plantar artery and vein. And if you look at this patient, look at this very clean lateral plantar artery, very low calcium burden, as opposed to this patient, a very high calcium burden. You can see the veins right here, and this is the occluded lateral plantar artery. And so when we prove occlusions, we do it just like we do anywhere else in the body. We're going to use B mode, color, and then we're going to put a Doppler in there to show it's Doppler silent. So it is the same technique that we use in any other bed of the body. So I just want to show a quick case of a high calcium burden patient. This guy that I showed you with the heel wound, he has a very complex case, multiple wounds, a lot of tibial disease, a lot of pedal artery disease, and we were able to revascularize him and get his PAT from abnormal to now normal. It was class 3, class 4, and now it's class 1, 5 months later, and he had all wounds healed. And these patients oftentimes present with disease on the other limb. So we can never ignore blood flow on the other foot. And just like we used to do bilateral ABIs, in my opinion, when we do a unilateral arterial duplex, we should always check the PAT in the other side of these complex patients. So when he had these wounds, he had class 1 flow and no wounds on the other foot. Now he presents 2 years later with this tiny little wound. And we've educated him to come back if you have any other wounds. And unfortunately, he was wearing ill-fitting shoes. He's insensate, so he can't feel his toes. The minute I put the probe down, what do we see? We see this high calcium burden vessel. And we see color skipping, not a lot of good color filling. But when we put the Doppler in there, he has a measurable class 1 or low class 2 PAT. And if you recall, to heal a wound, we need a PAT of less than 180 milliseconds. So no intervention needed here. We saw him 1 month later. His wound is nearly healed. It's just a little red. He's on some antibiotics, but he's doing really well. So you can see the value in using pedal duplex in these complex patients. Now let's switch to diagnostic accuracy because, to do anything correctly, we have to do the technique appropriately. So we want to have good, accurate results. So again, we want to lower that baseline down, decrease the scale. I suggest 4 cardiac cycles in the spectrogram. So regardless of what ultrasound system you use, you can tailor that sweep speed time to be appropriate. And then you're going to precisely measure from the onset to the peak of the arterial waveform. So examples of poor technique would be a really high scale where we can't appropriately measure. In this situation, this was measured really far over and from the baseline. So this would be an overestimating the PAT. And remember, we want to get, even if it's a hyperemic waveform or there's end diastolic flow, you have to place the caliper just at the onset of systole to the peak, and then just make the waveform size very appropriate. If you're concerned about your measurement, it is okay to measure multiple acceleration times in the spectrogram. I think it's important because this is not always perfect. These waveforms can be challenging to measure. And if you do that, you want to report out the worst PAT value of that waveform spectrogram. Nothing is perfect. And so we spent a long time poking holes in our own theory. So we need to understand where are the limitations of this technique? And I'm going to go through 5, which I think are important to recognize. The first is in the setting of significant hemodynamic inflow disease that's isolated. So common iliac artery occlusion, high-grade external iliac artery stenosis, even a common femoral artery that's a rock pile with a high-grade stenosis. But everything below that is widely patent. Now, if you think about that disease pattern and the comorbidities with that patient, they're likely a smoker, right? This is large vessel disease. And so you can use ABIs or any other tool. And you can use PAT, but just know that the velocity will be low and could be falsely normal. So in this situation, this patient has a low pedal velocity. And if we look at this velocity, my next slide is going to say when I think it's this one, when the velocity is 6 centimeters per second or less, that is automatically class 4. So I don't even measure PAT when the velocity is 6 centimeters per second. It's already in that bucket of class 4. In this situation, this is really bad flow. You can't even measure it. It is just continuous, and this would also be class 4 PAT. There's always going to be some tech-to-tech variability. We know that when we measure AAAs, we have 0.3 millimeters of variability. It's the same thing here. So if Ali were to measure this waveform at 80 milliseconds and I measured this next one at 64, we're still in that variability of class 1 PAT. And then, of course, as I said earlier, incorrect technique is also going to be a limitation. So for PAT, there's huge clinical indication in patients with suspected PAD and CLTI. I think in the wounded patients, patients with diabetes and renal failure, this really can provide so much value. And the nice thing is we can use PAT to really monitor our patients, not only pre-procedure, we use it inter-procedurally in the cath lab, but also post-procedure as surveillance as the patient is going throughout their wound healing journey. And I think the nice thing is there's so much clinical benefit to our multidisciplinary team, whether that's podiatry, wound care, vascular surgery, IR, IC. Vascular ultrasound really plays an integral role in the care of these patients. So this is a nice targeted quick assessment that can really evaluate what the perfusion is like to the wound bed. This poor gal dropped an orange juice jug on her foot, had never had any diagnostic testing, and the wound wasn't healing. I put a probe next to the wound. It's class 3 PAT. And we were able to open up the popliteal artery, got her to class 1, and she really healed nicely. I do like it for pre-planning for Uber distal bypass for vascular surgery colleagues to say, is the pedal arch open? Do we have outflow if we're going to do a long distal bypass? Yes, we can definitely assist with the distal target for bypass, the diameter, the calcium burden, but we can also have the confidence to say this patient has outflow when we do our distal anastomosis. This is a really important slide, and one of the most common questions is how do we report PAT? So I'm just going to take you through these bullet points. So in a non-wounded patient, maybe the patient has rest pain, maybe they have some foot pain, podiatry sent them for some reason. If you're going to do a pedal artery duplex, you want to report out the worst PAT in the pedal arch in a non-wounded patient. In a wounded patient, you would report out the pedal artery or the PAT leading to the wound bed. So if you look at these two scenarios, there's ischemic rest pain on this patient's right foot. The lateral plantar artery is 188. The dorsal metatarsal artery is 232. So this is class 4. We would report out class 4 PAT in this patient with ischemic rest pain. Now he's got this little non-healing wound in his first toe. PAT to that wound bed is class 4. If the PAT is less than 6 centimeters per second, that is automatically class 4. So these are three really important rules for how we utilize PAT in reporting. This is a really nice case illustration of a 56-year-old diabetic male, former smoker. He presents with this right second toe non-healing wound, is in a lot of pain. And you can see he's on the clinic table. It's a very busy clinic. And Dr. Tesso calls me and he's like, can we please just do a quick PAT so I can make some decisions? The vascular lab was completely packed. And this guy's, you can see his comorbidities here, his hemoglobin A1C is just a little bit elevated, but not too bad. So I'm bringing my ultrasound system into the clinic room and I'll start with flow at the arcuate artery wound bed, and it is so continuous, this would be automatically class 4. And if we jump up to this guy's distal anterior tibial artery, also very poor flow, a continuous waveform. Let me go back to the diagram here. So this is the value of PAT and kind of this like limited duplex in a busy setting. You know, when I'm thinking about this, he's class 4 PAT. We know that Dr. Tesso is going to intervene and he needs to know, triangulate the disease. He's got a multiphasic common femoral artery and distal pop is also stenotic. So he could do antegrade access safely to do his intervention. And there's significant disease in that tibial perineal trunk ATPT perineal region. Let me fast forward here to the case. So took him for an angiogram and you can see here that he has significant tibial disease. This is the occluded perineal, occluded anterior tibial artery, and almost functionally occluded posterior tibial artery. So we were able to get a wire and balloon the posterior tibial artery with a very nice result. And, we left the perineal and anterior tibial artery alone because look at this beautiful foot shot. This is a intact, complete pedal arch flow comes down the lateral plantar artery, retrograde flow around the arcuate artery with antegrade flow to the dorsal metatarsal artery to the wound bed. And on table, I could show, remember that PAT was flat. We now have a measurable class 1 PAT to the wound bed on table. We have an endpoint to be done. In surveillance follow-up, his PAT remained class 1 and ultimately he healed his second toe amputation very nicely and in a timely manner. So let's transition to other uses of PAT. And I think there's a lot to be said for these no option or poor option patients that are really challenging to revascularize. So this is a guy who has fifth toe gangrene. He has 4 centimeters per second to his dorsal metatarsal artery to that toe. This is class 4. When I think about the disease pattern of this patient, look at his posterior tibial arteries occluded. He's got 5 centimeters per second in his lateral plantar. How are we going to revascularize this guy? Yeah, I can do a GSV mapping if we think bypass, but really he has got small artery disease to this wound bed. And these type of patients, I am thinking about DVA. I'm thinking about how are we going to increase arterialized oxygenated flow to the wound bed. And regardless of where the wound is, these heel wounds can be very challenging. A forefoot ischemia can be very challenging. So there is a role for using PAT and pedal duplex in the mapping for pre-DVA patients. And so when we really understand the pedal anatomy, occlusions, flow direction, it can really aid the physician in their decision making. So when you see a disease pattern like this, I'm automatically going to trigger my mind to map the lateral plantar vein and great saphenous vein as well for them to make some decisions because these patients really, this is a almost no option procedure. This patient underwent an arterialization. This was a hybrid arterialization. You can see the patient underwent a guillotine amputation. The DVA ultimately went down as they do, but there's something new in the world of DVA that we're using pedal acceleration time for DVA patients. And this is something called pedal venous maturation. And you can see even within a closed DVA, this patient had arterialized flow to the new neovascular network, and she ultimately healed a 4-foot amputation and a heel wound. So what is pedal venous maturation? We just published our paper in the European Journal of Vascular Surgery, and pedal venous maturation is something that occurs with the creation of a deep venous arterialization. So DVA is the connection of an artery, so posterior tibial artery. We create an anastomosis into the pedal venous, or to the posterior tibial vein, and then we're going to deliver oxygenated blood flow through the arterial inflow, across the anastomosis, and through the pedal venous anatomy. And this is what the initial angiogram looks like. This space right here between the skin line and the lateral plantar vein is the Lejar's plexus. And if we were to do an angiogram 6 weeks later, we would see this new neovascular network that is now present after a DVA. And this is why DVA works. But we can't do an angiogram on every single patient for their post-op duplex follow-up. So we are going to evaluate those neovascular beds with duplex ultrasound. And when we see this new arterialized flow in the foot, we can now measure the venous pedal acceleration time. So this would be positive for pedal venous maturation with a measurable venous pedal acceleration time. So we do this test at the wound bed and at the bottom of the foot. And this is really, really helpful because we know that DVA, the circuit doesn't stay open long. We just need it open long enough to get the neovascular network established and to have positive pedal venous maturation. And this patient here, their DVA has been down, and you can appreciate all these serpiginous arterialized veins in the tissue going to the wound bed with a measurable arterial waveform. So I think this is a really exciting time for vascular ultrasound to play such a significant role in following these patients post-operative DVA. So in conclusion, PAT is a very nice additional tool that can be added to our challenging and changing patient population. It requires an understanding of the anatomy and proper technique for really accurate diagnostic testing. And it should be a part of an evolution of care in these complex patients, and that includes DVA or any complex limb salvage revascularization technique. What I would like to address is a couple of common questions that may come up is, where do we get training for PAT? Usually SVU, we have a workshop. There's multiple, we've done this for multiple years. I'll be at SVU this year doing the workshop again. You can contact me directly. There's online resources, there's publications. And a lot of people ask about time allowance. Just like anything, it takes time to become familiar with the technique and the anatomy. So sometimes it may take you 15 minutes as you begin, but after you're experienced, it can be a fairly quick examination once you're familiar with the anatomy and the technique. In regards to billing code, this is a 93926 billing code if you're doing just the pedal duplex ultrasound from the pedal arch and the distal tibials. If you're doing a full arterial duplex and the foot, it's all one billing code. And then in regards to integrating into the lab, I think there's a place for it in our diabetic and renal failure patients, but you also have to validate your own vascular technologists in the lab and comparing that to your ABIs or toe pressures, but there is certainly a role for integrating this nicely in complex patients. So with that, I'll say thank you very much. Feel free to contact me anytime with any questions, and I'll hand it back over to you, Ali.
Jill, that was a wonderful presentation. Um, we did have quite a few questions regarding the probe that is supposed to be used. Some
Mhm.
images had a hockey stick and a linear, so there was a couple questions, which is the best?
Yeah, it's a great question. So 90% of the time, I use a standard linear probe that we use for carotid. I will use a hockey stick or high frequency probe if the foot is small or if I'm getting on this tiny little dorsal metatarsal artery. So like anything, just use the probe that's appropriate to the patient in front of you.
There was a couple other questions regarding the time allowance. How long do you allow for pedal acceleration exams in your lab?
So for the pedal duplex ultrasound, if we're just doing PAT in the distal tibials, it's about 30 minutes, just to familiarize yourself with the communicating arteries and the target artery pathway. But as I said, once you become very familiar with this, you can, we can all probably do a carotid fairly quickly, because we do so many of them. Just like anything, your time will go down with practice and being familiar with the technique.
With multiple validation studies now done, are we now at a point where consensus statement guidelines can be added to textbooks and ultrasound educational curriculums for the IAC vascular testing guidelines to propose labs using PAT?
So I'll let Marge take this question, but I will say that currently there are multiple papers doing a systematic and or meta-analysis review of all the publications to date. And I'm working with other organizations on formalizing the PAT testing. So I'll hand it over to you, Marge, to answer the second question.
Yeah, anything new takes a while in medicine to catch on, and we really haven't had too many. Excuse me, we really haven't had too many new things coming along, and so I think it's going to take some time. But I certainly think that this is so informative, so much more than just a non-compressible AVI. I mean, you gotta admire this work.
Thank you, Marge.
When these patients come back for post-operative follow-ups, are you doing full arterial duplexes with PAT or just PAT?
I love this question. That's why I had these slides ready. So the algorithm that we use in our lab that worked very well for Dr. Tesso and other physicians that I work with is that on the first examination, we do the full arterial duplex because we are mapping for intervention. Patients always come back at that 1 to 2 week mark for an initial follow-up. And that's where I think that limited pedal duplex can be really helpful. We just want to know, is the blood flow improved after intervention? And so this is where we can optimize the vascular lab. We can still bill the 93926, take 30 minutes to evaluate the wound bed, scan the pedal arch and the distal tibials, and say, yes, the PAT now is class 1 to the wound bed. Then when the patient comes back for their 1 to 3 month follow-up, we definitely need to do the full arterial duplex, especially if there is stents, if there's a bypass. You want to make sure there's no in-stent stenosis or distal anastomosis stenosis. So we can't lose sight of that for sure. But one of the other really beautiful things about the pedal duplex scan is when we are working with our wound care and podiatry colleagues. So let's just say that we did the revascularization, we did the 1 to 2 week post-op, it was class 1, and 2 weeks later, the podiatrist calls or the wound care doctor calls and says, hey, the wound is stalling and it's getting worse. In my mind, that is a same day add-on to the vascular lab for a limited pedal duplex scan. This is 30 minutes. We can, even less, we can scan the wound bed, the pedal arch, and give everyone the confidence to say the PAT is still class 1. Maybe there's infection, maybe they need offloading, maybe there's something else going on. Or, gosh, it's class 4. Now we can go find the source, like is the bypass down or is the stent occluded? And what this does is it expedites patient care. And we all know that time is tissue. And so if we can help get the patient in quickly and evaluate, it will just, serve the patient better in their overall wound healing journey. So hopefully that helps with kind of the algorithm. I'm happy to send people an email if you want to know more, but this works very well for us.
Are there published normal velocities for the pedal loop?
No, Not yet, but we are working that. We know that a PAT of less than 6 centimeters per second is class 4 PAT, but in regards to average pedal velocities, that paper will definitely be coming out in 2026. We don't generally, we rely more on the PAT than the velocity, but I think there's some curiosity to know average pedal velocities in the foot, and we have that data.
Mhm.
Do you need an ABI and TBI when pairing with a PTA duplex?
So in this type of setting, it depends on the patient in front of you. And to Marge's point, I mean, if this patient is diabetic and you've already done an ABI that was non-compressible, I think it's safe to just continue on with a PAT. I
Mhm.
don't want to overstep, Marge, but I think you know times are evolving, and I think this is an exciting time, as you said, Marge. So,
Yep.
Marge, you
Yep.
have anything to add to that?
I do have a question though.
Mhm.
Like, what's the learning curve? Like, everybody gets off this webinar, all of a sudden they want to start doing this. What do they do? How do they get there?
Yeah, so I shared the PDF, and I think, and there's many papers. The Journal for Vascular Ultrasound has a very nice paper that we wrote on the technique paper. So if you understand the landmarks of the foot and where to place the probe
Mhm.
and what to see, start scanning. If you have a extra time on a rule out DVT or a normal arterial duplex or a reflux, just start with one vessel on the top of the foot. Start to see the dorsalis pedis arcuate artery and start to just see the same anatomy and practice PAT. And then you can move on to the lateral plantar artery and medial plantar artery if you have time. I will say that if you start to scan your colleagues that are young and healthy, they're a little bit challenging. Like, we're just too healthy. So I would suggest to scan and practice on, a patient that
Mhm.
these vessels are just a little bit more generous in size and easier to see. I would also suggest too, like, if you can come to SVU or come to any other major conference that offers it, you can do live hands-on scanning. Um, Now, I trained a lot of maybe some of you that are on this webinar, and hopefully people who are more experienced can start to train others.
Mhm. Right. Right.
There was a question asking if you do any personal training.
I do, yes, and feel free to contact me anytime.
And how can they contact you?
It's in the resources, Allie. Just my WhatsApp number or email is okay. Yeah.
Let's see. How does PAT compare to absolute toe pressure in terms of wound healing potential?
Yeah. So we did that really nice paper, the diagnostic accuracy, and it's comparable to, toe pressure. So when the toe pressures, um, we can use the absolute toe pressure in comparison to PAT, and they're almost spot on. So take a look at that paper.
Is there a separate examination with a unique CPT code, or is this an additional, in addition to a lower extremity arterial duplex? How would a physician order for PAT?
Yeah. Very good question. So the arterial duplex and PAT is all one CPT 93926. You just can't bill the extra foot because it's just a continuation. But if let's just say this is an inpatient and this patient has a toe wound, they can certainly order a PAT duplex 93926. You can go to the floor. Maybe you used to grab your big ABI machine, but the patient's diabetic. You can do a PAT, a pedal duplex, wound bed, PAT measurements around the foot and distal tibials, and build the 93926.
Mhm.
I think we have time for one more question. Um, if you have a patient with no wound with a class 3 or 4 PAT, would they need an intervention?
So it just depends on on the patient and the vascular specialist decision. But generally, this patient has ischemic rest pain if that's what they present with. Of course, we always treat the patient, not the image. So PAT is just an additional tool that we can provide for any of that clinical decision making.
Okay. I think we might actually have one for just one more.
Okay.
Um, Let me see, there are so many good ones. Arteries in the foot can be retrograde or antegrade. However, what is the correct direction for the plantar arteries?
Yeah, so the arcuate is an antegrade towards the toes. That would be antegrade normal flow. And then on the bottom of the foot, antegrade flow towards the toes in the lateral and medial plantar artery. But remember, we can, just like the palmar arch, we can have a complete palmar arch, or we can have an incomplete pedal arch. And sometimes we don't see retrograde or antegrade flow because the pedal arch is not intact. So retrograde flow is not a bad thing. It just means our body is, collateralizing just like it would around the circle of Willis. So, but normal flow is towards the toes on the top and the bottom of the foot. And I will say, I hope you find joy in scanning the foot. I think it's really exciting from a vascular technologist perspective,
Mhm,
and
mhm.
hopefully many of you will say the same thing. It's really nice to be able to share with our vascular colleagues that we now can say what the perfusion is like in the foot and give them more information on their decision making. Again, we are such an integral part of the multidisciplinary care for these complex patients.
Marge, do you think we have time for one more?
Sure, do one more.
Yeah. After a DVA, does the PAT criteria change?
Okay, now I'm really getting excited. Yes, so in this in this fetal venous maturation paper, DVA changes the physiology of the lower limb, and what we found in our data that's published is that the arterial PAT improves after a DVA. So think about two different beds. So we have the arterial PAT that we still have to assess after a DVA, but now we have the pedal venous anatomy that we also evaluate. Yes, we want to know patency and flow volume, but we're also looking for pedal venous maturation in that new neovascular bed. And that's where we will measure the venous pedal acceleration time. So the criteria in the arterial tree does not change, Ali. And then the venous pedal acceleration time, we are working on that validation number now. So it's really evolving and becoming a really helpful metric in how we follow these patients post-operatively, because they're hard. They're hard to evaluate, but we're getting there. It's very exciting.
Well, Jill, I mean, everything is so exciting. It's so fun to have something new coming up in our field. Let me just say that there are many, many questions, and that we will get to your question, even if it wasn't answered here. We'll get a printout of those questions and we will get you the answers. So I want to say thanks again, and a very special thank you to Jill Sommerset for this
Thank you.
presentation today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The link to the survey will appear on the screen automatically at the conclusion of the live session, and also be available from the IAC webinar portal for 3 business days. On the left side of My Account page, you'll click on Webinars, look for the title of this session, Pedal Acceleration Time, Technique, Criteria, Interpretation, and Clinical Application. Beneath this title, you would click the review event, then click Take Evaluation to complete the survey. Your certificate can be accessed and printed from the very next screen and anytime thereafter through the CE transcript section in your IAC webinar account. Please note that this certificate will not be emailed to you. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we want to thank you for joining us today, and we appreciate your participation.